So hello and welcome to another episode of the AtheroTalk podcast, the podcast series hosted by the EAS Young Fellows. My name is Fotis Barkas from the Faculty of Medicine in the University of Ioannina in Greece, and I will be your host for today's episode. Professor Raal is currently a distinguished professor in the Division of Endocrinology and Metabolism, as well as director of the Carbohydrate and Lipid Metabolism Research Unit, University of the Witwatersrand, Johannesburg, South Africa. He has authored or co-authored over 350 original articles and book chapters and has reviewed for several international journals, including the New England Journal of Medicine, The Lancet, Circulation, and Atherosclerosis. He's also on the editorial board of Atherosclerosis and was a board member of the International Atherosclerosis Society. Professor Raal is particularly interested in lipids and lipid disorders and has been integrally involved in the management of familial dyslipidemia and in particular heterozygous and homozygous familial hypercholesterolemia. His unit has one of the largest cohorts, if not the largest one, of homozygous FH patients in the world and has contributed and continues to contribute to the management of these patients. The major focus of his research remains the clinical, biochemical, genetic, and therapeutic management of this condition, and he continues to conduct studies with novel therapies such as PCSK9 inhibitors and ANGPTL3 inhibitors in this patient group. So, hello, Professor Raal. It's a pleasure to have you here with us today to discuss your trajectory and your opinion on the future of atherosclerosis research. On behalf of the EAS Young Fellows, I would like to thank you for accepting our invitation.
It's actually a pleasure to be here.
So in this series of interviews, you want to give our listeners the chance to get to know more about you personally and about your research and academic career. So could you please introduce yourself to our listeners? Who is exactly Professor Frederick Raal?
So I'm an endocrinologist. I'm based in Johannesburg, South Africa. I started off in general medicine, but then I specialized in endocrinology. But my research interest, after I'd seen a young patient with homozygous familial hypercholesterolemia, is lipid and lipid disorders.
Thank you. And could you please describe a typical day in your life, if there's such a day, and explain to us, please, how you can manage to balance your research with your leadership role?
Yeah. So in my previous position as head of endocrinology, we had a very big clinical load. So I had daily clinics. We had a thyroid clinic, a general endocrine clinic, an osteoporosis clinic, and a lipid clinic once a week. So I was very involved in a very large clinical load. So my research was confined mainly to after hours and weekends. But the advantage of having a big clinical load is that you're seeing patients with interesting conditions that often stimulate your research. And as I see, when you see these unusual patients with conditions like homozygous familial hypercholesterolemia, you think, well, is there something I could really do for these patients that would change their lives?
Do you have any advice for those aiming to or starting to manage multiple responsibilities at the same time? How did you manage to combine your clinical and research tasks together with many leadership roles?
Difficult, as always. It really depends. I think you can't, people that are not interested in research, it's very difficult to force them into research. But I think the excitement about medicine and that is asking questions and seeing if you can offer better to patients. So we must never forget medicine is about treating people and treating patients. And I would just encourage anybody. I mean, I've really thoroughly enjoyed my research career. Although I had a big clinical load, the research is really what kept me going.
And now we get to know you a little bit more personally. Could you tell us, please, more about your academic journey and what actually led you to focus on studying atherosclerosis, lipids, lipoproteins, and generally cardiovascular diseases from the epidemiological point of view? How did your journey start and which obstacles did you have to overcome?
Yeah. So as I mentioned, I just finished being in my general medicine and was starting to specialize as a physician. And I saw a young patient at the time, he was only 8 years old, with homozygous familial hypercholesterolemia. So this is more than 30 years ago, and at that time we only had one drug available was a drug called cholestyramine or Questran, which is very difficult to take, and it unfortunately didn't work very well. And that got my interest. Could we do more for this very young patient? That was at the time when statins had just started, so it was the early 90s, and he was actually one of the first patients to receive a statin at my institute, and he did respond, but unfortunately he died about 6 months later. But since then, there's been remarkable, developments in the field, and it's been amazing to see how from where we had very little therapy and these patients were dying at an extremely young age, they're now living much longer than they used to.
So I think that was the specific time that you decided to become a physician, also a scientist, right?
Correct, yeah. So I just thought if I could do more for these patients and look at, try and do the science behind it, we may be able to offer them more.
Great. So we are all aware that mentorship plays a crucial role in many successful careers. Did you have any mentors who influenced your path and whom you admired and directed your academic journey?
Well, I had a local mentor who had started the sort of lipid clinic. He was a chap called Harry Seftel. But really, I was fortunate as a young student to get a lipid grant sponsored by a pharmaceutical company, which allowed me actually to come to Glasgow and to learn a little bit about lipids and lipid turnover. It was the time of the WASCOP studies. Jim Shepherd was here. Chris Packard, who's still around, was here. So that really stimulated my interest because they were doing the basic science and looking at turnover studies. And that what stimulated my interest at the time and took me on my sort of research career.
Yeah. At the same time point now we are Glasgow. So,
Yeah.
And lastly, within this section, can you tell us about some new project that you're excited about this time?
Well, there's two sort of areas. One is I still don't think we know all the answers in terms of lipoprotein a. We know that on the African continent, levels of lipoprotein a in Africans are much higher than Caucasians, etc. Yet we're not at the moment seeing much coronary artery disease, aortic stenosis. I think there's a lot of questions that need to be answered. So I have a young fellow who happens to be an EAS fellow as well, who's answering questions in that area. But the real excitement as well is that we're about to embark on gene therapy or gene editing for patients with homozygous FH. And I think that will hopefully be the future, the sort of once and done, where we've got good medication, but it does mean daily taking these medications daily, etc. So I think the gene therapy is a very exciting new field in medicine.
Yeah, totally agree. As a physician myself, I think that both projects are very interesting and very promising in the upcoming future. So let's get now to your expert opinion. We know that you have recently participated in a post-hoc analysis of a PCSK9 targeted therapy of phase 3 trials involving patients with cardiovascular disease or any cardiovascular disease risk equivalent recently accepted for the application in the European Journal of Preventive Cardiology. So what's your opinion on the evolving role of these drugs in lipid management, and particularly in high-risk populations where traditional lipid-lowering oral lipid-lowering therapies may be insufficient?
Yeah, so that's an important question. I mean, if we go back a decade or two, we only had statins and ezetimibe, which, I mean, statins are remarkable drugs, but particularly in patients with familial hypercholesterolemia and definitely in their homozygote patients, high-intensity statin together with ezetimibe did not get the LDLs reduced sufficiently to the targets. So the discovery of PCSK9, as you know, Marina Abba-Fable was involved in that. She had a patient that looked like they had familial hypercholesterolemia, but there was no mutation in the LDL receptor, and that's how PCSK9 was shown to be a cause of FH. We now know it's remarkably effective. The treatments directed against PCSK9 can lower LDL cholesterol another 60%. So for heterozygous patients, the addition of these therapies, and in fact in patients with atherosclerotic cardiovascular disease, this has really been remarkable therapy. We do have 2 outcome studies with the monoclonal antibodies. We are awaiting an outcome study with the siRNA, which is easier to use because it's much less frequently. It's only given twice a year. But if you believe in LDL as the cause of atherosclerosis, I would be extremely surprised if that study does not have a positive outcome.
And we must not forget the homozygous FH individuals. So, how do you envision the role of combination therapies like statins, PCSK9 inhibitors, lomitapide, or angiopoietin like 3 inhibitors? Should we think maybe a fire and forget strategy for such high risk patients, trying all of the available drugs?
I think that's an important question. Unfortunately, they need a lot of therapies to get them anywhere near the currently recommended targets. So high-intensity statin, ezetimibe, plus a PCSK9 inhibitor just does not get them to that target. So and those are all what we call receptor-dependent therapies. They all depend on the LDL receptor. So the newer therapies are really for the severe homozygotes, which are LDL receptor independent. And that's drugs like lomitapide and the ANGPTL3 inhibitors, which on top of the other therapies can reduce LDL by another 50% or so. It is extremely difficult because they start with such high LDLs, even with everything together, all 5 drugs together. We would struggle to get all our patients to these very low targets. So the important message for homozygous FH is to identify these patients as early as possible, to initiate therapy early, to prevent them having that burden, that LDL cholesterol burden, rather than waiting and only starting at the age of 30 or 40. We need to start as early as possible in these patients.
Thank you. So before closing our interview, I would love your future perspectives in a few matters. So as a clinician, what are the key unanswered questions regarding the long-term efficacy and safety of PCSK9 targeted therapies for lipid-lower? And what insights do you anticipate from the large cardiovascular outcome trials?
Yeah. So I think in terms of PCSK9s, fortunately, we have a genetic example. So we have patients that have loss of function mutations in PCSK9, and they could be homozygous for 2 mutations, and they live normally, their brains work, everything's okay. So fortunately, we've got a natural experiment to show that this therapy is probably safe. Similarly, with ANGPTL3, there are patients that have loss of function mutations in ANGPTL3. So the data to date has been remarkably consistent. There haven't been any long-term serious adverse events, but like with when we started with the statins, we thought they were the answer to everything. And now, after long-term use, we do see there's a signal for the increased development of diabetes. But the cardiovascular risk reduction with these agents markedly outweighs the tiny risk of diabetes. So I think we need longer term data with PCSK9 inhibition. If you think the mechanism is the same, upregulation of LDL receptors, we have LDL receptors on the beta cells. So in theory, with long-term use, there may also be a small signal of increased risk of diabetes in people predisposed to diabetes. But time will tell. But otherwise, it's a very clean class of drugs, and it's a huge benefit, particularly for patients with familial hypercholesterolemia.
And another problem that happens with long-term or even lifelong therapies, ideally initiating from childhood, is the adherence. It's very difficult for the patients to maintain the therapy. So as an expert of FH and lipid-lowering therapies, how do you envision the use of genome editing tools to treat FH once and forever? Do you feel concerned about this topic? And what do you see the possibility to make changes on epigenome levels instead of on genome levels, as recently suggested by Capellut et al. Publication in Nature? Do you think that we are ready to take such a big step?
I think in the correct patient, so for example, a young patient with FH who's had a myocardial infarction in their 30s or something, they now have to consider being on their lifelong therapies, often triple therapies. So if there is this approach of once and done, where they can then reduce, and they know they can reduce their levels to pretty good levels, we've started asking patients, because we're now going to be involved in these studies, and definitely they're considering it. The benefits of genetic versus epigenetic, as you know, gene is editing the gene, and that's like permanent. Epigenetics may be safer, but we're not sure yet of the long-term, the long-term consistency. Will that if you just edit the epigenome rather than the gene, what is the long term? We know from genetic editing it seems to be once and done.
And in this regard, we should not forget the public health issues that derive from the availability of such expensive drugs in the market. So what do you think that we can do in order to bridge the treatment gap of homozygous FH patients in low and middle income countries where such therapies might be very, very expensive and unavailable?
Yeah, so I think that's a very important question, because at the moment it's really only the homozygotes that are in affluent countries, first world countries, because these drugs are expensive. So we definitely have to move, and that's one of the, in terms of HIC, which is the our register of homozygous patients. What is on the agenda is how can we get these medications to these very deserving patients. The fact that you live in a third world country should not exclude you from having access to these life-saving drugs.
Exactly, thank you. So now that we are coming to our end, we always have a section dedicated to failures, which we call the graveyard of ideas. So most of the time, we only hear success stories of other researchers, which makes some of us question ourselves. We want all researchers to know that failure is part of the process, so we decided to ask everyone in this series of interviews to contribute an idea to our graveyard of ideas. This could be a story about a grant you were passionate about that did not work out, or any kind of failure you faced during your academic journey. So what is your contribution to our graveyard?
So that actually comes back to Glasgow. So in those days, Daniel Steinberg, who you may know, felt that LDL itself wasn't bad. You had to oxidize or change LDL. And there's a very old drug called probucol, which is an antioxidant, which one of the first drugs we used in homozygous FH that caused regression of the xanthomas. But the problem is it also lowered HDL. So HDL was thought to be good in those days. So we thought at the time, rather let's try another antioxidant. So we actually used very high doses of vitamin E. And so for a year or two, our patients received very high doses of vitamin E. We were hoping that if we didn't oxidize the LDL, it would help. Unfortunately, the xanthomas progressed. It did nothing to the LDL cholesterol levels. So although we know oxidation may be important, giving antioxidants was a failure in this group of patients. Fortunately, we now have drugs that lower LDL markedly, and I think that's the first and foremost. But I would say that was my graveyard, as it were, a therapy that just didn't work for these patients.
Thank you so much for sharing your experience with us. So within the podcast, we also want to inform our listeners about the possible open positions in different academic institutions around the world. Do you usually announce your open positions, or would you encourage researchers looking for a PhD or postdoc position to write directly to the labs that they are interested in? And how did this work in your institution?
So in our institution, unfortunately, because there's this big clinical load, availability of jobs are mainly for clinical practice and not on the research side. So we've got to be inventive. I mentioned I fortunately have a young EAS fellow, and he's managed to find funding independent of the hospital. So self-funding from a research institute, and allowing him to do his research. So I think, people have got to look at it's difficult to find jobs. If we do have a job available, we would advertise, but most of those are clinical jobs and are full. And if you want to encourage people that are interested in basic research or research, it's often very difficult to find that post, and you've got to find alternative means to find the funding to be able to do what your heart wants you to do.
So this was an incredible interview. Thank you, Professor Raal, for sharing your time and insights with us. So also a big thank you to all of our listeners, and this podcast is for you, and we need your feedback to tailor it to your interests. So please don't forget to leave us your impressions or suggest topics that you would like to hear more about, and stay tuned. And again, thank you very much, Professor Raal.
It's a pleasure.